So one of the key factors to remember from NMOSD is that if they have a relapse, it tends to be a very aggressive relapse that can lead to disability with not a full recovery afterwards. So one of the concerns if we're transitioning therapies would be that we want to make sure that that time frame while we're transitioning, there's not a big gap between it, because a patient may have a relapse and they could be left blind or unable to walk, or even worse because of that transition. So that would be something to definitely take in account. When we compare it to MS, we know that MS may have a relapse, but patients may recover from the relapse or may be less debilitating. It's not the same with NMO. Because of how the disease behaves, it tends to be very aggressive, leading to that sometimes permanent disability. So that would be something that we have to be very mindful when we're transitioning a patient from one therapy to another. If we think a little bit about NMOSD, the name was given in the 1800s as the Bick's disease, and for many centuries we didn't have therapies, FDA-approved medications. So these just started pretty recently. And it has made a huge difference because patients used to be disabled or even die from the disease because of a very aggressive attack. And we're seeing that landscape change. So I think one of the main things that we have to consider as clinicians is diagnose early. The risk of misdiagnosis is also pretty high, and that can lead to a patient being diagnosed years after they presented with the disease and already have disability. So diagnosis at an early stage and starting then on one of the FDA-approved medication really makes a big difference in how the patient is going to do later on. So again, the diagnosing early. If a provider is not comfortable with the management or diagnosis, refer to a center which they are with urgency. But also one of the questions that we all have would be, there's now 4 different DMTs for NMOSD. Which one would be the best one for the patient? That will also depend on each patient, so it's individualized. Is the patient young? Are they planning to get pregnant soon? Is the patient older? That transitioning that we were talking about. So I would say from the end of MS specialists, what we can do to improve all this would be educating other physicians, care providers like mid-levels to be able to recognize the disease. Sometimes NMOSD may present with not your typical optic neuritis and transverse myelitis, so it may be an area postrema syndrome, brainstem narcolepsy. So sometimes it's difficult and the diagnosis can be delayed, and that could lead to that permanent disability that I was mentioning. So I think definitely education from our end and recognizing early disease and treating it as soon as you diagnose somebody, putting them in an FDA medication. Also educating the patient that they need to be on that medication and the reason why, because of this being so aggressive and disabling.